Hello, my name is Niels Halama. I'm a medical oncologist at the National Center for Tumor Diseases in Heidelberg and also the head of the Department of Translational Immunotherapy at the German Cancer Research Center in the DKFZ in Heidelberg. I'm going to talk today about the NOX812 drug therapy in pancreatic cancer and in colorectal cancer patients, which is the data from the OPERA trial as presented at the ESMO virtual conference this year. So this is the layout of this phase 1/2 trial, combining the substance NOX812 plus immunotherapy, which is pembrolizumab, in 20 patients with either metastatic colorectal or metastatic pancreatic cancer. As you can see from the chart here, there is a baseline tumor biopsy followed by a part 1 where there is a single treatment with the NOX812 substance, followed by a second tumor biopsy, and then the combination phase combining NOX812 plus Keytruda. So this allows us, of course, to see what the changes are induced by NOX812 within these patients, and to assess also the side effects produced by the monotherapy with NOX812. NOX812 is a Spiegelmeier that is a novel approach where the backbone of RNA molecules is used to create a drug with a mode of action that is unique here. So NOX812 inhibits SDAF1 alpha and is a specific highly selective inhibitor. So with this being said, the primary endpoint is to understand the changes and the specific changes induced in the microenvironment by NOX812 with a focus on immune cells and cytokine and chemokines. And of course, for this the second part, the endpoint is to assess the safety and efficacy of this combination treatment. Now here's a little bit about the demographics of these patients. As you can see, the vast majority of these patients are heavily pretreated. They have received all standard of care treatments, multiple treatment lines, 4, 5, 6, 7 lines of previous therapies, and all these patients are microsatellite stable. So they have all been tested and they have not shown any signs of microsatellite instability, either by PCR or by immunohistochemistry. So you can see that these patients were all progressing on prior therapies, and they have had a roughly 1.5 months between the last treatment and before coming onto the trial. So here is a summary of the effects that show that there is a specific effect induced by NOX812 and showing that there is a specific increase in the target molecule CXCL12, which is expected because the neutralization of CXCL12 by NOX812 prolongs the half-life and leads to an increase within the tissue. The change from baseline is seen in these patients, but you can see that there are differences, and the magnitude is correlated with an immune activation and also the clinical benefit. So looking at these changes, these cytokine changes and activation markers in the tissue, one can see that there are 3 main classes or cassettes, if you wish, of responses in these patients across pancreatic and colorectal cancer. So there is a group that we would call tissue responders because they show a IL-2 interferon gamma IL-16 increase upon NOX812 treatment. And that's a specific pattern that comes up in these patients. And then there's the opposite, the tissue non-responders. They have a more immunosuppressive myeloid signature with IL-1 and IL-6 increasing only, So that is something that is clearly the opposite of this more Th1 type IL-2 interferon gamma cassette. And then there is a group in between that have only a mild interferon gamma IL-2 effect. They show some changes in the CXCL9, CXCL10 chemokinaxis, but as you can appreciate here, this is sort of the in-between between these two larger cassettes, the tissue responders and the non-responders. So with this being said, there is a difference between tissue responders and non-responders in terms of cytokine patterns, and this is here summarized comparing day 14 biopsies to day 0 pretreatment biopsies. You can see there are specific changes, especially for the IL-2 interferon gamma and CXCL10 and IL-16 here, that are highlighted and are clearly visible and statistically significant. Another interesting aspect of this observation is that this is not only limited to the cytokine or chemokine patterns that we see, but also there is a shift in the distribution of the T cells within the tumor microenvironment. So NOX-12 in the responder leads to a shift in the distribution pattern of T cell densities towards the tumor. So what you can see here with the dashed line is the comparison of the baseline situation to the treatment situation, and you see that the densities of T cells in the proximity bands towards the tumor are shifting towards the tumor. So the 0 to 10 micrometer band and the nearer ones are increasing and shifting from the farther away bands towards the nearer ones. And in the non-responding patient, you can see that there's practically no change. There's no indication that there is a shift in this pattern. So that's something that's quite obvious also from this analysis of the proximity of T cells to tumor cells. And another fascinating aspect of this treatment is that if you look at the skewness, the distribution patterns of T cells in general in the tissue, that you see in those that have a response, there's a dramatic change in terms of aggregation, conglomeration of T cells, which is typically regarded as an activation marker and seen in patients that have a clinical benefit as well. So this is clearly linked, and something that's not only in terms of a direction or directed movement towards the tumor, but also a conglomeration and activation of T cells. So now if you look at the clinical data, there is an unexpectedly high number of patients with long-term survival. And you have to keep in mind that these patients all have had massive pretreatment with multiple lines of standard of care chemotherapy before. And you can see that there are the number of patients that are really surviving long-term after trial participation as well, and have clearly shown a beyond expectation survival in this setting. So you can see here on the length of the bar that there is a follow-up period that reaches the 2-year time frame, which is clearly beyond the expectation in some of these patients, for sure. So in this aspect, the colorectal cancer patients had 6 lines of therapy on average already, and in pancreatic cancer it was the 4th line of therapy. So that's a massive pretreatment in the situation. And close to a quarter of them had a prolonged survival after being treated within the OPERA trial here. So this is also shown here on the progression-free and overall survival plot here, the Kaplan-Meier plot. There is roughly a quarter of the study population that survived for more than a year, and that's also reflected here in these plots. Now, coming to the safety profile and toxicities, there is clearly a signature here that shows that this is very well tolerated. So what you expect in a setting with a checkpoint inhibitor is these classical side effects with autoimmunity, with abdominal problems, and that's what you can see here and appreciate here as well. So it was very well tolerated. There was no indication that there is a problem with the NOX-A12 dosing here. So there's, from this data, we can see that there is certainly much more variability and possibility in dosing NOX-A12. So it was very well tolerated after seeing this in all these heavily pretreated patients. So in this situation, we think that that's, from the perspective and the clinical perspective, that there is a really unexpectedly high number of patients with prolonged survival here. We see disease stabilization following the combination therapy in these patients. Also actually seeing that there is a time on therapy prolongation in the trial participants as compared to their last previous therapy, which is quite amazing because the expectation for immunotherapy is typically the opposite direction, that you have shorter intervals on the progression-free survival and in prolonged overall survival. But here we also see that there is a prolonged progression-free survival in these patients with the immunotherapy on the trial compared to the last chemotherapy, so that there is a reversal of this effect that is also observed in the OPERA trial patients, which is quite surprising to see. There is a specific pattern in the chemokines and in the distribution patterns of immune cells in responding patients that is clearly reflecting a Th1 type reactivity that is being induced, so that the treatment with NOX-A12 makes the tumor more hotter or immunologically more active in a sense, and that is something that's really unique here for these patients, and shows that it's a safe combination treatment that has immunological activity in heavily pretreated metastatic colorectal or pancreatic cancer patients. That there is a induction of an immune response and clinical benefit derived from this, and that's something that is a safe combination that allows to treat these patients with this combination of checkpoint inhibitor and NOX-A12 with an anti-SDF1 alpha treatment. That is interesting also maybe for earlier lines of treatment or even other combinations here, so that there's still plenty of room to explore. So thank you for your attention, and of course we'd love to hear from you. Take care.